Just as the nurse was about to put down the white padding that was over my incision, my mother said, "Wait a minute, there's something on her stomach. Looked like a mole." And my mother asked the nurse to call the doctor to come back, and she didn't want to. She said, "I am not going to call the doctor for what's going to turn out to be nothing." My mother said, "I'll call the doctor." I'll never forget, I was looking at my doctor and I raised the gauze and I just saw his face completely change. And when I looked down at my abdomen, the black dot was gone and there was a quarter-sized pustule. The infection kept spreading and it was starting to go down my leg. Over 2 million patients a year get hospital-acquired infections. I ended up having 6 more surgeries, 9 blood transfusions. I left the hospital with an open abdomen that took 3 years to close. My hospital, they were cited for being in violation of 5 state laws and 10 federal laws for unsanitary conditions in their operating rooms. It took me 10 years of almost weekly physical therapy to get back to a new normal life. I spent this past year, 2017, fighting for my life all over again. I went to the hospital with a sinus infection, and they said, "Okay, we're going to keep you because it looks like you're starting to be in the early stages of sepsis." Well, the next morning, the infectious disease doctor came, and he said, "Oh, great news. We're going to send you home." And I said, "Really?" And he said, "You know my history." I said, "I'm a survivor of sepsis, Pseudomonas, MRSA, VRE, and necrotizing fasciitis. Can we wait until my labs come back before you discharge me? And, I'd like to see what some of the cultures are saying." And he goes, "Oh, we didn't do any cultures. We don't need that. And, we did a test for pneumonia and influenza, and you're fine. You don't have those. So we're going to go ahead and let you go home." And I said, "Well, can I get a second opinion on that? Can we talk to someone about that?" And he said, "I'm the best infectious disease doctor in the Valley, probably the state. Any other doctor is going to tell you the same thing I'm telling you." I ended up having 2 more surgeries, 2 more blood transfusions, deep vein thrombosis, blood clots in both arms. I was right back where I was 5 years before. And it really cemented for me the need to change the way we teach doctors, the way we treat doctors, the way they interact with patients and patients interact with them. We need to start sharing patient experience with our medical students, with our nursing students, so that they can get it from the horse's mouth. When you're building your house, your profession, you want to make sure that you build it on a solid foundation of patient safety.
It's a major reason why we've seen 50,000 fewer preventable patient deaths in hospitals. And if you want to know what that means, ask Alicia Cole, who suffers the long-term effects of a hospital-acquired infection.
We've learned a lot in healthcare, and we're better than we were 10 years ago. We're doing great at talking about patient-centered care. We're doing great at talking about preventing errors. We've got to do better in the action of it.
Greetings, everyone, and welcome to our panel on high reliability. My name is Dave Mayer. I'm a cardiac anesthesiologist by training, but serve as the executive director of the MedStar Institute of Quality and Safety. And I had the honor of serving as the CEO in the past of the Patient Safety Movement Foundation, a great organization. And we're excited to be part of this program today. I'm going to turn it over to each of our 3 panelists, first starting with Abdelela. I'd like them to each introduce themselves and give us a little background about why this topic is so interesting and exciting to them. So Abdelela, why don't we start with you?
Thank you, David. Hi, everyone. So my name is Abdullah Al-Hawsawi. I'm a transplant and hepatobiliary surgeon, both American and Canadian board certified. I'm also the former founding Director General of the Saudi Patient Safety Center, and have been and continue to be involved in patient safety through the WHO and other global efforts. Why this is important to me as a practicing surgeon, patient safety is a kind of a near and dear to my heart topic, and even though, in spite of the great, the good intentions on our part as providers, we continue to harm patients. And given that high reliability industry, like especially aviation, given my brother is a pilot in Saudi Airlines, I've come to learn a lot about why that industry is safe, but also I got a great interest during my time in the Saudi Patient Safety Center to look into other industries like oil and gas, like nuclear. And I think there's a lot that we can benefit from them in terms of the science of safety and what it is that we can, contribute and introduce to healthcare. I mean, these are different industries, but I believe there are some similarities where we can learn a lot from them that I'm, very much interested to discuss throughout our panel.
Let's keep in alphabetical order. So Keith, I'll go to you next. Let us know a little bit about you and who you are and why this topic is important to you.
Thank you very much, and hi everybody. So Keith Conradi, my current role is I'm the Chief Investigator of the English Healthcare Safety Investigation Branch, which is a government organization purely set up to do safety investigations into healthcare incidents happening in England, where we don't apportion any blame or liability, but look to understand the systemic reasons why an event happened. But my background is aviation. I'm an ex-military and civilian airline pilot. And for 14 years, I worked with the United Kingdom's Air Accidents Investigation Branch, kind of the UK's equivalent of the NTSB. And for the last 6 years there, I was the chief inspector. And I didn't really know much about healthcare and the events that went on, but I was asked to contribute to a government panel, an inquiry as to why in healthcare the same events kept happening and we weren't getting any learning, and to sort of give the aviation perspective on why the same wasn't true in aviation, how safety had improved so much. So that's why I made the switch across and tried to bring some of those principles of safety investigation into healthcare. And I look forward to discussing that further later on.
Thanks, Keith. Michael, tell us the great work you've been doing up in Rochester and why you're excited about this panel.
Well, thank you, Dave, and hello, everybody. Great to be here and be part of this. I've been a consultation liaison psychiatrist, which is basically a psychiatrist that goes to see patients in the hospital, med surg, OBGYN, and so on, but have been trained in an area that's very aware of a biopsychosocial explanation for medical illness, and actually kind of seeing how that actually does play out in clinicians as well. What are the environmental effects that can affect the well-being of clinicians that then affects patients? I've been part of, as medical director of our wellness program at University of Rochester, and then I was involved at the state level, our medical society, and then was asked to be part of the Federation of State Medical Boards task force on burnout to kind of look at how burnout affects patient care and patient safety. I also, in trying to make sense out of all this stress and what technology has been doing and the information overload, how to put those ideas into words that a layperson might be able to understand, certainly a healthcare leader, so that we can make better designs so the environment in which we're taking care of patients improves, so they were more likely to be doing the right thing and avoiding the wrong thing. Our malpractice carrier awarded me a patient safety award to be able to educate leaders on human factor-based leadership. So it's been the combination between wellness and patient safety has been extremely important to me, and I'm very excited to be here and be part of this panel. Thank you.
Great. And I too am very excited to be moderating this panel and hearing all your wonderful thoughts on the topic. You know, let's start off with one of my favorite quotes was James Reason's. You know, we all know "To Err is Human." It was the title of the Institute of Medicine report. And you know, James Reason says, we can't change the human condition, but we can change the condition under which humans work. HRO and resilient science has been studying this for over 30 years and have shown great success in other industries. So I'll start, Keith, I'll start this question with you and then go around to our other two panelists. What is it that we could specifically learn over this 30 years of research that aviation and others have figured out, and how they've changed their culture to one of top priority safety?
Thank you. I mean, I think it's a really interesting point, because if we go back 30 or 40 years in aviation, we were in real trouble and incidents were continually happening. And so something did have to change. And I think since then, the sea change has been that actually people have thought about safety as its own sort of profession or system. And that is the culture now, that if somebody comes into aviation, from the very, very beginning, they understand the huge significance that safety plays. And it becomes just part of your everyday experience. We have the just culture, so it is absolutely okay to be able to speak about something that you see, because people understand that you come to work planning to do a good job. And it's not necessarily you, but it is the environment around you that actually contributes to where something may go wrong. And the fact that, you know, little errors occur all the time, but the system in place stops those from being critical and leading to harm. And I think the thing really for me is the fact that it is thought of as a system, and something that we often describe as a safety management system is pretty much mandatory in airlines across the world. And that means that it's not only systematic, but it's proactive. And it requires the organization to think about safety before the event occurs. And I think that's the thing that I see in healthcare. It still needs to do an awful lot of catching up to sort of not just react when something happens, but to be thinking about it in this systematic way. And one of the big things that we often are starting to recommend when we do investigations is that people implement a proper safety management system. And more work seems to be being done in that area, but I still think it tends to be the work of, dare I say, enthusiastic amateurs, as opposed to absolutely done in a professional basis. So that's perhaps the biggest thing that I would see is the difference.
Great, thanks. Michael, let's go to you next. Where have you seen successes, or you believe we can bring successes into healthcare through this 30 plus years of research and learning by other high-risk industries?
Yeah, I've been looking at it from kind of a clinician on an everyday basis and trying to see what happens to the environment in which you're working. So seeing studies about where do most of the errors come from, looking at that. I was very interested in one of the studies that was put out, I think it was by Press Ganey in 2018, about only about 13% of the medical errors were knowledge-based errors. And when you add up all the other reasons, the issues of cognitive load by your environment and all kinds of other distractions created about 87% of the causes. So what can we do about that? So looking at the most common causes of errors are system-based, and realizing that the most common reasons for clinician burnout are system-based. What can we do about the system? So upstream, what are decisions that could be made differently that and create the environment we need to more safely practice and to sustainable practice, something you could do for 40 years and not cutting back your hours and so on. So one of the main things I've seen is kind of the end-to-end view of a system, as Keith was putting it. The whole system has to be involved. We're looking at clinicians that pull, as part of the culture, when you're on call, you stay up, but there's some things that are human-induced that if we get it to the eyes of leadership who can help us, such as, for instance, you're working on your electronic medical record, doing paperwork much longer because the system that was built was not functioning that well. How can we keep track of how long a person's working after the last patient is seen so they're better rested the next day? We keep a better eye on that in other professions than we do in healthcare. So upstream, tracking more of our whole day, the workload, and allowing us the space for cognitive restoration, basically, so we're better the next day.
Great. Thanks, Michael. Abdulela, you've been doing great work across Saudi Arabia and throughout the Mideast. I'd love to get your thoughts on what are things that we could be bringing into healthcare today that other industries have learned in regards to be, reducing risk.
Absolutely. So just to carry on the just culture aspect of HRO industries and the safety culture. But back in 2016, we actually had a visit to Saudi Aramco, the oil company, with the team from the WHO and a couple of other safety experts, and we it was an eye opener to see how an industry that has on a daily basis thousands of drilling operations, it pretty much goes seamless and you don't hear about those operations, just because even though on one hand they're very risky, on the other hand the way that safety is practiced in that industry is very different from what we do in healthcare. And it took a question that I asked to one of the engineers about their compliance with guidelines to kind of just give me an idea about the safety culture, because what I asked them at that time is, what's the compliance rate with guidelines? And it was very much a kind of a confusing question to them, because he said, what do you mean? What's the compliance? It's 100%. And anyone that works in healthcare knows that clinicians, and especially us physicians, we tend to not have that kind of conformance, if you will, to the system, and rather than conforming to the system, we basically have our own ways of doing things, and that's why I don't have this almost 100% compliance rate. The other part is our satisfaction with the fact that 1 in 10 patients would be harmed in one way or another. I think those industries like aviation, like nuclear, like oil and gas, just keep pushing the envelope to reduce whatever very, very few numbers of harm. And you know, one feature of the HRO industry is preoccupation with failure. So if harm happens at step 10, we in healthcare, we intervene, I would say, at step 8 or 9. And many times we intervene even after step 10, after the fact, whereas in those industries, there's always this focus on intervening upstream, you know, in steps 1, 2, and 3. So that's another big difference in how proactive those industries are when it comes to looking at safety and dealing with it. And one final point is, and I think Keith alluded to it, which is, you know, the system approach to safety. If you attend a root cause analysis exercise in healthcare, you would find out that the majority of the recommendations are you know, training, and writing a policy. And we had back in 2018, when I was in the Saudi Patient Safety Center, we had an event where we had a panel of safety experts from nuclear, aviation, oil and gas, in addition to healthcare. And you just listen to the language of the nuclear safety expert, rather than writing a new policy and focusing on training, which is more of an individual approach to the system. You know, the nuclear safety expert was talking about how can we engineer in solutions to the system? How can we engineer out problems? So less focus on individuals, more in the system. Whereas in healthcare, there's a big focus on individuals, less in the system. So I think that's another area that we can learn from those industries as well.
Well, thanks. You know, I always found there were certain things that were just so simple. When we started our HRO initiative back in 2012 at MedStar Health, just the idea of doing a safety moment at the beginning of a meeting, 45 to 60 seconds on an issue, whether it was a good issue or something that didn't turn out well. And starting every meeting, our board meetings, our leadership meetings, I didn't care if it was finance or marketing or legal, everybody would start with 45 seconds about a safety moment. And it re-ingrained that safety was our number one priority across an organization. And it was just amazing how quickly that got adopted and how much it really raised the bar. It's just one of a number of things, tools, techniques that have been implemented. You all touched on, starting with Keith, the idea of, you know, our history of shame and blame and trying to get to a just culture mindset. Lucian Leap has said many times the single greatest impediment to patient safety is that we continue to punish people for making an error, making a mistake. So, you know, this time I'll start with Michael. Michael, talk to us a little bit about just culture and your beliefs. You've done a lot of work about wellness, and how do we ingrain that model into our event reviews, that we're not using older methodologies of trying to find out who is responsible and using newer methodologies like aviation and others that tries to find out what was responsible.
Right. That's really such a challenge. I totally agree in terms of the root cause analysis issues, to kind of break open the idea of how well-meaning decisions could be made, but can cause error downstream. And just the whole idea of not placing blame, but just the fact that it can happen, and talking more about that. Because I agree with our discussion. We have so much emphasis on the individual and how far back ultimately it was maybe their hands or their decision that made the error, but what about all the how upstream decisions may have affected resources or that's why the idea of education on human factors to kind of ideas that we need to budget brain power as well as money and space and other things, that we can do something about what are the tasks that a person is having to do when they're taking care of patients. So are there decisions upstream? Maybe it would pay, for example, to have more help in the clinic or to do faxing or to do call people back, et cetera, to relieve the brain power. And so if we open our thinking, it's kind of like breaking, there's a cartoon once about a little chick breaking out of an egg. Oh my gosh, it's a paradigm shift. Now I'm outside of the eggshell. I can see the whole rest of the world now. The idea that beyond that eggshell, there are lots of things that contribute to an issue. And if we start to think about how it can actually affect somebody by affecting their brain resource at the time of their decision, we have a whole world around us that we can start to make an idea about. And maybe it wouldn't be taken as personally, I would hope, as we try to see where decisions were made and how we can do things differently. But to try to diffuse the issue of blame, absolutely. But just to realize that this is human nature. We're all in the human club, so this can happen.
And Abdullah, I'll go to you next. Same question, same conversation. How do you embed just culture within an organization, and what might you share with the panelists as well as their audience on things that you've done to raise that bar?
I think it really has to come from the top in terms of is it a top priority of the not just the C-suite, but even the board, the whole saying of like from the board to the word. So is safety a top priority? One of the things I saw in Aramco is, and you mentioned that the safety moment. So every meeting, there's actually a safety notice about, where are the emergency exits? Today there are no fire drills. So if you heard that there's an issue, so it literally, I came out of that trip feeling that safety was being treated as religion in that industry. So I think putting a lot of emphasis on safety at the board level, at the C-suite, and beyond. One thing that we need to do is we also need to think of co-production strategies to help with safety. So, just out of my simple practice as a surgeon is, talking to patients and families about reminding myself. So when I'm doing rounds, I actually make a point of telling the patient in front of the team and the nursing staff that, not to allow anyone to examine them without washing their hands. And I told them, jokingly, even myself, so if I come to you and I'm not haven't washed my hand, just remind me. And that is kind of empowering patients on the spot. I think if we really want to try to make a sustainable impact and an improvement in safety, we can't do it alone as providers. So we have to bring patients and families to co-produce this with us as we move forward. So that's one aspect as well. One couple of points also that I kind of just remembered right now that come to mind from aviation is the idea of a sterile cockpit, where at certain altitudes there isn't a conversation about last night's match or what have you. So it's all business effective communication, and I don't see a lot of sterile conversation in the operating room, and I think there's a lot of room for improvement for our communication in the OR. In the ward, when a nurse is administering medications and then he or she gets distracted by us coming in to do rounds, that's an opportunity for making mistakes. So do we have sterile cockpit concept in protecting the nurse who is administering medications? And then the other one quickly is the minimum equipment list in aviation, so that an airplane would not take off if that minimum equipment list of safety is not guaranteed. And when it comes to healthcare, there's a lot of many instances where we actually take off, if you will, figuratively, without having that minimum equipment list. There's an article that I wrote back in 2020 at Buzz News called "If Hospitals Could Fly," and it's about kind of making that concept of making sure that upstream you have a minimum safety situation, in nurse to patient ratios and in equipment and etc. before you start providing care. So these are kind of some of the thoughts I have also about your question.
Great, thank you. And Keith, I saved you for last on this one because the aviation industry clearly has figured it out much better than healthcare in regards to training their interviewers, going to areas of mishap or danger immediately. In healthcare, we wait for 3 to 4 weeks before it's convenient for our schedules. Share with us your experience through the years and how aviation has moved the concept of just culture into its mindset.
Well, again, 40 years ago, you've probably seen some of these programs where you see this what we would call a very, very steep authority gradient in the cockpit, where the first officer or the co-pilot wouldn't dare challenge the captain, even though he or she really knew that they were going into an incredibly dangerous situation. And there were some major accidents that happened when the focus absolutely became on this authority gradient and bringing it down to an acceptable level where challenge was understood, accepted, and part of the sort of day-to-day operation that might go on. And I guess aviation is also quite lucky in that with such an emphasis on simulated training, we were able to embed that sort of culture every 6 months as pilots went through that particular emergency training and all the different scenarios. But the other thing that I've noticed is that in aviation, most states have one regulator. So, we have the FAA in the States, we have the Civil Aviation Authority. And I was quite surprised coming across into healthcare where there are a vast number of regulators. And what I've seen now, trying to work with them when we're working at the safety recommendations, where do we aim the improvements that we think are necessary as a result of the investigations? And there are so many, and we will go to one and say, okay, we want to recommend you do X. And they'll go, oh, it's not for us, it's for this team over here. And they will say the same thing. And we end up ping-ponging this sort of workaround, and it either falls between the cracks, or you end up with conflicting guidance or regulation from two separate or more separate bodies. And trying to untangle that has been, I think, a major headache that I see in healthcare, which we just didn't get in aviation. It was more straightforward, and there was also much more emphasis on mandating things, what I would call hard regulation, as opposed to I see a huge amount of guidance. And I do understand that that is necessary sometimes in healthcare, but it's extraordinary, the guidance and the autonomy with which various groups interpreted this guidance, which again, I think lays open this area where mistakes can lead to harm occurring. A bit as we were hearing earlier, where you're looking, why isn't it 100% compliance? Well, we kind of do our own thing over here. We just look at the guidance in the background somewhat. So I think those are some of the major differences.
No, thanks. It was some wonderful comments from all of you. And to our audience, I mean, there's a number of great resources out there around fair and just culture, from James Reasons to David Marks. And, you know, Sidney Decker is another one that I really like, that it's written a lot on the topic. And the idea that we embraced was, you know, the science of safety is not just systems and processes, but there is accountability. Because if we blame the system and process every time when there was preventable harm, that would almost be anarchy, where anybody could do what they want. But there was an element of accountability when those that do care in a knowingly reckless way and put somebody at harm, we also as leaders have to be responsible and accountable to act on that and to ensure the safety of our patient population. You all have talked about in your comments today the importance of human factors engineering and how it fits into high reliability mindsets. You know, Michael, I'll start this question with you. You've done a lot of work around here, especially when it comes to, as you mentioned, physician wellness and burnout and things. Share some of the work you've been doing and where you think healthcare needs to move further in this area.
Okay. I think the idea of application of human factors, if you think about all in healthcare where we currently use it, if you think of kind of vertical hash marks on a timeline, after an accident, we certainly do helping at the point of the patient care between the individual clinician and the patient, the best design of medical devices, so we're using those properly. What are the interface between human and the device? But the work I've been really trying to do, because I've seen so much effect of it, is all the kind of decisions that could be made with better clarity and reducing stress on the clinician if there was just some harmonization of what the expectations and understanding a total load would be. And it's exactly what Keith was talking about, at least in the US, about so many regulations that don't necessarily connect at the top or communicate well. And if they're all coming, there's actually a human-induced new problem that's creating more of a risk for error, in the sense of using up our brain power to just figure out, when do I need to get this done, then, and so on. So just if that's where in the hands of leadership that have so many decisions that affect resources, the culture, and other issues of safety in the environment, if leaders knew a little bit more about the potential impact on a person's thinking, doing the work, just by some knowledge, that I think we have great opportunity to make a difference for patient safety right there. And so what I've been trying to do, and I now have partnered with a human factors engineer, Kate McNamee, who I met in Chicago at a conference for human factors in healthcare. She was presenting on best design, cognitive ergonomics and best design. I was talking about human factors for leaders, and we got together and drew up some models together to try to help a lay person, at least somebody not new to human factors, that is new to human factors engineering, so that they make sense to them and in a way that helps show relationships. So that's the area that I'm hoping to do more of, is kind of a curriculum for leaders that I hope will be in current healthcare leaders, and I hope it would be useful leaders in training for their MBAs, their MHAs, and just enough so that they're able to apply this in the resource allocation that they have control over.
Great, thanks. I've been blessed through my career to I've had people like Terry Fairbanks, somebody who spent a lot of time in Rochester, come and start the National Center for Human Factors Engineering, and now Raj Watwani, who oversees it. It's just amazing to understand that mindset. I joke, that side of the brain never developed for me. I could never really figure out those things. I go, how did you just figure that out? That's amazing. But I always turn to them to get those solutions. Keith, you know, you've been in the mix of it all in this space. You know, share your thoughts.
I think it's interesting when we come to do an investigation where something obviously has gone wrong. We use something called SEEPS, which is a System Engineering Initiative for Patient Safety, and it's a methodology which really means that it forces us to look at the whole system. So we understand that there is a person who is doing a task with some tools in an environment, in an organization, sitting in a regulatory space. And we try and understand how they all connect with each other so that we take it away from the individual who might be at the front line. And we try and understand all those interactions. And then where can we make the interventions that will prevent this happening again? And then when we come to the safety recommendations, and it's a bit like Abdullah talked about earlier in terms of there's a kind of a hierarchy of effectiveness here. And right at the bottom is the old do more training and thicken the rule book. But right at the top, which is really where we try and push ourselves, is in the automation, the forcing functions, almost the things that take the human out of the loop as much as possible. Because we know, as you started off the whole thing by saying, that humans will err. That will happen. So the more we can automate some of these processes, the better we think the system will be in the long term.
Great comments. And I remember once sitting next to a pilot on a panel, and after the panel, I found it very interesting in his description. He says, you know, pilots are more risk mitigators today. The planes can fly themselves. I mean, we know that with drones and other things. But what our job really is to understand the risks and mitigate them with our experience, our knowledge, our simulation training, whatever it may be, that provides for a safe experience for all. And that comment stuck with me. Abdullah, you know, your thoughts on human factors. You spent a lot of time in your career in this field.
Yeah, let me answer your question in you know, through an operating room environment, because I think, you know, everyone agrees with me that probably that's one of the riskiest areas in a hospital. One thing that we need to do a better job of is to have team-based training. So in a way, the outcome, which is, you know, safe, effective outcome for individuals, is dependent on the effective team and the whole system working together. But if we want to kind of just come down to this micro system within the operating room, the outcome out of the operating room is dependent on the anesthesia team, you know, with the surgical team, with the nursing team, working together. And unfortunately, and I've worked in different countries, we still have this, what I call them the tribes. So there's the surgeons tribes and the anesthesiologist tribes and the nurses tribes. And we hardly have training together, and I think you know, so you how are we going to have effective you know, teamwork to get a safe outcome without having team-based training? So the simulation that you know, Keith talked about, I think we really need to start doing simulation of an entire team to really kind of integrate those human factors into our day-to-day activities in the OR, and I think the same applies to different environments. We really need to kind of re-examine the kind of the whole medical education and healthcare education and training, where the outcome is dependent on these different parts working together. We continue to have the style training, different groups of healthcare professionals. So the human interactions are always not ideal. We can always do more if you're thinking about it from a human factors engineering. And then you can get into the human technology interface, and if you focus also on the human interface, where we talk to patients and families. And I think unless we think about them as kind of interdependent parts and basic things like having tools to have effective communication, we will continue to have potential errors which could lead to harm.
Yeah, thank you, Abdulela. It's great thoughts, especially the operating room comparison. One example for our audience that I thought is one of the best demonstrations of how to use human factors and incorporate that just culture mindset is a YouTube video called Annie's Story. It's ANNIES. It's a wonderful video about a nurse who misread a glucometer, resulting in a patient receiving a dose of insulin that put the patient into hypoglycemic shock in ICU for 24 hours. The woman recovered, did fine, but the nurse was devastated because she had read the glucometer wrong. The hospital at the time decided to punish the nurse and show that, as you point out, we either punish or we retrain or we repolicy. Once human factors was brought in and did their evaluation, they realized there was a fault in that glucometer, that anybody could have read that reading wrong. In fact, when they went in their event review, they found there was another nurse who read it wrong 3 months ago. So the treatment wasn't to blame the nurse and to punish her. The treatment was to take the glucometer out of the system and find one that was designed well, better for humans not to make mistakes. So it's a great example. I know we're at the end of time, and I want to thank Keith. I want to thank Michael. I want to thank Abdulela for a great conversation. HRO is so critical to any safety culture, and hopefully our panelists have shed some light and some views on how you can incorporate that within your health system.
¿Por qué estamos comprometidos con la seguridad del paciente? Antes que nada debemos de saber qué es seguridad del paciente. Eso significa ayudar a disminuir los riesgos que se pueden causar o daños a las personas en atención a la salud. ¿Y de qué manera podemos hacerlo? Con las metas internacionales, las cuales llevamos día a día aquí en el Hospital de María.
En el Hospital de María, para convertirnos en un hospital HRO, nuestros pasos son aceptar, reportar y aprender a reconocer todos los errores ocurridos para así generar una buena atención y seguridad a nuestros pacientes.
Calidad en el laboratorio es un mecanismo diseñado para detectar, reducir y corregir deficiencias analíticas antes de emitir un resultado, aumentando la confiabilidad del mismo, para que el médico pueda dar un tratamiento y seguimiento adecuado para el paciente.
Para ser un hospital HRO se debe contar con confianza, honestidad, tecnología e integridad.
¿Por qué estamos comprometidos con la seguridad del paciente? Porque los pacientes son la parte más importante de nuestro trabajo. No poder asegurar la seguridad del paciente es antagonizar con el principio más importante de la medicina. Primero, no dañar.